Good morning, everybody. Welcome to the World CP Day, IAACD 2021 Global Listening and Sharing Sessions, where this year's theme is diagnosis or functional approach. Is this even a sensible question? As a member of the IAACD Global Organizing Committee, I would like to thank the Touchpoints National University Children's Medical Institute for holding our session. Firstly, some housekeeping. All recordings will be posted on the IAACD website for public access. So if you do not wish to be recorded or would like to remain anonymous, please keep your video off during the session. Do not comment in the chat during the session and rename yourself as a participant. By actively participating, you consent to your appearance and comments being recorded for all future uses. Cerebral palsy is the most common physical disability that affects the movement and posture of 17 million people worldwide. We may think a child has CP, treat and intervene based on the diagnosis, but what if the condition is a CP mimic? Based on the ICF, a diagnosis gives us an idea of the limitation and function due to the effects of the condition on the child's body, structure, and function. The impact of just basing care on the diagnosis of function has its pitfalls. The challenge is, how do we find the balance between optimizing function, inclusion, and participation in relation to the diagnosis? There is also a need to change the emphasis on fixing the disability. Today, our speakers will discuss diagnosis versus function, cerebral palsy, when it's not what it seems. Our speakers for the session are Associate Prof. Stacey Tay, who is a Senior Consultant Pediatric Neurologist at KTP and UCMI, with a special interest in neurogenetics, neuromuscular disorders, and neurodegenerative disorders of childhood. She will be followed by Mr. Chandra, who is a Senior Physiotherapist at the SPD and has been there since 2012. He provides intervention in early intervention for infants and children under the age of 6. And finally, we have the Song family. Ryan is a patient of KTP and UCMI. Daddy CK is a commercial pilot with a local airline, and prior to that, he was a military aviator with the Republic of Singapore Air Force for 2 decades. Mummy Paymay is an HR professional, and they will share their stories about living with Ryan. I hand over to you, Stacey. Thank you.
Thank you so much, Laura. Allow me to share screen. Okay, so I really want to thank the organizers for giving me the opportunity to speak at the IAACD Global Sharing Session. And cerebral palsy is a topic I think that we all know a little bit about, but perhaps not everything about CP. And I'm hoping that today I'll be able to shed a little bit of light on when CP is actually not what it seems. And the story of CP is truly an evolving story. I'm not sure if many of you know that it was in the mid-19th century that Dr. William Little, who was an orthopedic surgeon, was the first person to record the observation of spasticity in children. And actually for a very long time, spastic diplegia was known as Little's disease, and we don't use this eponym anymore. But you'll be surprised that actually some of the concepts that we have in CP today are actually not very old concepts. For example, the classification of CP into spastic, dyskinetic, hypotonic, and ataxic actually only started in the 80s. And the GMFCS, the Gross Motor Functional Classification System that we are using so commonly nowadays, was only published in 1997. So things are changing and relatively quickly. So the term cerebral palsy is something that we all recognize, but time and again, especially when I teach medical students, I have to remind them that cerebral palsy is a descriptive and it's not a diagnostic label, because the term, it's what I call a bit like a basket or a box term. It gives you a label that you can use for accessing services, but it doesn't tell you very much about the etiology of the condition. So to me, labeling somebody with cerebral palsy is like putting that person in a box with a label, but there is what we need to do as clinicians is to remember not to leave the child in the box, but to look inside the box every once in a while, because there are different times in the child's life that requires us to re-examine the diagnosis and how well we are doing in intervening in their lives. So this is we know that cerebral palsy is a non-progressive condition, but yet from this chart, you can see that the motor function or the motor skills can actually change with the age of the child. So if you have a typically developing child, obviously you have very quick early development, and you can see motor skills are achieved, and it tends to plateau because, you know, by a certain time you learn how to walk, run, and so on. But you see for the patients with cerebral palsy that they will change over time. The milder children will change, have a better motor trajectory than the more severe patients. But these lines actually tell us that all our children do have a particular potential that they can reach. And so therefore, there are some periods in life that we will be very attentive to. So the first period is obviously the first 6 years of life, because we label this as the work very hard period of time. And this is because brain plasticity allows some early developmental changes. They're very sensitive to the environment, to external stimuli. And this is a time where early intervention is truly a golden period where we can get the most out of achieving good developmental goals. But then the other time in life that we would actually pay attention to would be in puberty. And the growth spurt in puberty is actually a problem because these children actually grow fast, and their bones may actually grow a little bit faster than the muscles, and simply because of the shortening or the inadequate growth of muscles, they actually go into abnormal postures, or with time as well, more contractures develop. And what we find is that patients who have been able to walk, perhaps with assistance, may actually start to need to use the wheelchair. And this is a significant loss of function, which sometimes families are not prepared for. And finally, the other period that we would worry about is when they're getting older. We notice that family supports are changing, and the social supports like school, they come to the end of school after 18. And so therefore, we worry about the future and how we're going to help them manage. So when do we actually need to look into this box? I'm going to suggest that we need to look at the patient at presentation, and in the aspect of what if you're dealing with, are you really dealing with cerebral palsy? I think we need to ask that very, very early on. And then as time goes on, we need to revisit the diagnosis, simply because sometimes the CP mimics actually do not present with abnormal features very early, but over time they may develop more features of say movement disorder, or there could be fluctuation of symptoms that become more obvious to you. And so we need to revisit the diagnosis as well. And of course, finally, before it's too late, when we need to actually put in some forward planning for the good of the patient. So so I think traditionally we recognize that cerebral palsy is usually caused by prematurity, perhaps some kind of a stroke, and less commonly things like birth asphyxia. But and also for these patients have the MRI scans, we do expect to see certain kinds of changes. But cerebral palsy mimics can look like CP. This and the symptoms actually can start below 2 years of age. They tend to be either non-progressive or slowly progressive. And what may tip us off is actually if you did do an MRI scan, that the MRI may look normal or may have some non-specific features. So because it looks so close to cerebral palsy, the typical cerebral palsy, we need to actually start to suspect CP mimics if, for example, on history, there are absence of risk factors for brain injury in the prenatal, the perinatal, and the postnatal period. So what kinds of risk factors are we talking about? We are talking about prematurity, low birth weight, multiple births, a history of hypoglycemia, especially soon after birth, any severe jaundice or kernicterus, intrapartum asphyxia, intracranial hemorrhage, stroke, or trauma. If there is a family history of cerebral palsy as well, we should be very alert because cerebral palsy is not inheritable and we would suspect a genetic condition. If the child had any kind of normal motor development and then later on had motor difficulties or developmental regression or progressive symptoms, we should be very worried. If there are fluctuating motor symptoms or motor symptoms that come on intermittently, we should also be very alert that this is not typical. If the child has an illness and decompensates and loses function, we should also be concerned. If the child has any generalized hypotonia of extremely prominent ataxia, I know we have the ataxia CP category, but the truth is a lot of ataxic CP have genetic conditions. So we might need to consider whether these are CP mimics. If there are signs of peripheral involvement, it's not a central nervous system involvement, so sensory loss, absent reflexes, or if there are any eye movement abnormalities, we should indeed be very concerned about whether we are dealing with a CP mimic. So let's look a little bit at the neuroimaging. Okay, so for classic CP neuroimaging, I think the important thing to recognize is that there are certain things that we see on MRI. So we look for things like cerebral malformations, periventricular leukomalacia, white matter or gray matter injury. So if you follow with me on this image, the left, this is a patient who is a left hemiplegic cerebral palsy. You can see there's an obvious polymicrogyria on the right hemisphere, and that is accounts for his symptoms. This is a patient with a diplegic CP who has got typical periventricular leukomalacia. This is a patient who has got dyskinetic CP, who has got some gray matter changes in the basal ganglia and globus pallidus. And this is a patient who has got ataxic CP, who has got atrophy of the cerebellum. And this is very much in keeping with the clinical signs. For CP mimics, one of the common things we get is actually a normal MRI. So if you don't see an abnormal MRI, it warrants a little bit of worrying. But sometimes you may see some specific and some non-specific signs. So for example, in this picture here, you see a globus pallidus signal abnormality. And we see something happening here, we worry about iron deposition. Or in the middle pictures where you notice that there is abnormal white matter signal. So in T1 imaging, it looks hypo-intense, and T2 imaging, it's hyper-intense. And usually this is what we call hypomyelination. And this tells you that this is probably one of the hypomyelinating disorders. And you may also have focal atrophy. So this is one of the classical pictures of glutaric aciduria where you have frontotemporal atrophy. So I apologize for this very, very busy slide. We are not going to go through all of it. But what I want to emphasize is that when we look at cerebral palsy, we tend to look at it in different categories. So is it a spastic CP? Okay, a dyskinetic CP or an ataxic CP. And one of the things we want to think about is the patient overlapping in any of these categories? Because if the patient overlaps quite a bit, you need to start to worry about, is it truly just CP alone? So for example, in glutaric acid, in GLUT1 deficiency, the glucose transporter deficiency, these patients have a static spasticity, but your clue is that they get movement disorder as well as ataxia that can fluctuate with feeding, they can fluctuate with exercise. The other thing that you want to pay attention to are some unusual features. So for example, if there is fluctuating or diurnal variation, if the patient has oculogyric crisis, or if the patient has got other signs that are not typical. So for example, systemic signs like autonomic symptoms, breathing pattern abnormalities, sleep apnea, recurrent vomiting, we need to start to think about whether we are dealing with some kind of a metabolic disorder. And the truth of the matter is that most of these patients who are CP mimics either have a genetic disorder or they actually have an inborn error of metabolism. And so if you have a patient that you suspect a CP mimic, this is a proposed algorithm from Toni Pearson and her group. And usually what we would do as neurologists very logically is to do the MRI, and sometimes we might do the spinal cord MR as well if we think that there are cord type symptoms. And if the MRI is abnormal, you can actually go straight ahead to do a specific genetic testing based on your findings. So for example, if you found globus pallidus lesions, that you would want to actually look for any of the iron deposition conditions. However, if the MRI is not so specific, then you can actually take it according to the constellation of symptoms and do a metabolic workup, which would include specific tests, say, for example, the usual thing that we do, the amino acids, the acylcarnitine levels. But sometimes for specific conditions, you may want to direct your testing to your clinical suspicion. So for example, in a patient who has got ataxia, you may want to do serum alpha-fetoprotein because you think about things like ataxia telangiectasia. Or if you can actually do some mitochondrial genetic analysis, because it's well known that CoQ deficiency is one of the treatable conditions that present like ataxic CP. Of course, if your metabolic testing comes out negative, you should still consider doing more extensive genetic testing. We are talking about whole exome sequencing or whole genome sequencing, because this often gives you a chance of picking up anywhere from 30 to 60% of at least a 30% to 60% chance of having a positive result that is useful to the family. And I just want to emphasize here that it is important to understand that nowadays, because we know so much more, we've got next generation sequencing and so on, we've been able to identify a lot of inborn errors of metabolism. And Leach et al. Actually identified 67 IEMs that are actually CP mimics. And almost 2/3 of them actually could be diagnosed on simple blood and urine metabolic testing. So I think in our workup, we need to remember that metabolic testing is one of the important tests that we would include in our armamentarium. So just to, to emphasize that CP is a label and not a diagnosis. And so therefore we need to pursue the etiology, especially if somebody tells you that, this patient has atypical CP, or perhaps this patient seems not to have done as well as you expect with the therapy, the Botox, or the surgery. We need to revisit the diagnosis. So when do we also need to look into the box? We need to look into the box as time goes on. So we need to think about when function seems to progress at an atypical pace. So there are many things that can actually derail function. So we know that if you have things like epilepsy or contractures or poor growth or nutrition, that function can suffer. The other thing we need to remember that, of course, for CP mimics, depending on the original primary condition, they can have a different trajectory compared to typical CP. Other things that can also play a role would be family factors. So in certain families, they may have disconnect of expectations, or sometimes after a while they get caregiver exhaustion. And sometimes as they get older as well, as parents get older, and they may actually not be able to look after the child that well, and therefore they may not have as much support for the child. And so that can derail function too. And some of the problem is actually with us. I call it a systems failure, because as a society, we may lack the resources to support these children, especially when they get older into adulthood. We also, as clinicians, may fail to recognize the problems that are staring us in the face. And finally, we may actually lack the understanding of what these children or adults need in their daily lives. We also need to look into the box before it's too late, because we need to plan for the future. And cerebral palsy is not a condition that is static, and therefore what we do now actually has a lot of implications for the future. So for example, good posturing, of maintaining good posture in the chair, doing bone health assessments and intervening appropriately will actually have a lot of impact in the future. What I remember was when I was a young registrar, I had a patient with severe dystonic cerebral palsy. And out of the kindness of my heart, I saw him sitting in a very terrible wheelchair, but I thought, okay, they can't afford it, so let's not disturb them. He's happy, they're happy, the parents are happy. But years on, he actually developed because of his very bad dystonic arching, he developed aspiration pneumonia, and he had a lot of swallowing dysfunction, and he finally passed away of pneumonia, of course. And so that really taught me not to be too kind, but to anticipate problems and to work on what is preventable so that the patients could have as good quality of life for as long as possible. So there are a couple of evolving touch points that I think we need to pay attention to. So firstly is learning, to make sure that the child is future ready. It could be a job or it could be the care of the patient. Feeding, because you need to make sure that the feeding route is appropriate and the posture is good for feeding. Nowadays, with assistive technology, we can give our patients a voice and a say, so communication is something that we must work on. We also need to talk to the child as well as the family about what their aspirations are and what does it mean to live life well with CP. Travel is something that COVID-19 has stolen from us, but we need to remember it's not just traveling overseas, but even for our children to get outdoors, to be able to engage with the world and community is important. And finally, for caregiving, we need to have realistic forward planning. We know that sometimes when parents plan ahead and they think the sibling is going to look after this cerebral palsy individual, that is enough, but that's sometimes not enough, because you actually need to train the sibling or the people who are going to take over care. In children who have CP mimic and not classical CP, some of these conversations about lifespan, care plans, and family expectations should actually take place earlier, especially if the child has a life-limiting disorder. So I hope I was able to give you some insight on the concept and workup of CP mimics, and so allow me to pass the time over to the next speaker.
Thank you, Prof. Stacey. I will start the next video now.
The link between diagnosis and function. Good morning, everyone. I'm Chandra here, a physiotherapist who is working in the early intervention program for infants and children in Singapore for the last 14 years. Early intervention program for infants and children. EIPIC is overseen by the Early Childhood Development Agency, which serves as a regulatory and developmental agency managing key aspects of children's development below the age of 7 in the early childhood and the early intervention sector in Singapore. ECDA is an autonomous agency hosted under the Ministry of Social and Family Development. Within EIPIC setting, the emphasis is to optimize the function of the e-child to support functional outcomes for clients and their family in their daily life. This is achieved through the use of the early childhood holistic outcome framework. In my professional experience, I have found that both the diagnosis and functional approaches are important in the clinical management of children with a physical disability. It's important to integrate both the diagnosis and functional thinking in clinical management. The role of diagnostic thinking in clinical management of physical disability is helping us to plan for effective treatment in the case of progressive medical condition. It's also helping us to select appropriate treatment strategy for different diagnoses. The role of functional thinking in clinical management of physical disability cases is actually treatment strategy can be embedded in an individual daily routine. An individual can engage and participate meaningfully in his environment and daily activity. What ECHO framework? ECHO provides a unified framework for early intervention service provider to measure functional outcomes for children and their family, such as those impacting the child's social relationship and self-help behavior. This family-centered approach aims to optimize the potential of children with special needs by bringing early intervention from therapy setting into the daily experiences. It guides and set out standard and common goal for early intervention professionals like teachers, parents, and other key persons involved in the child life. How the ECHO framework works? We start from functional assessment. This happens two ways. One is a home visit observation and another one school-based observation. Based on information, we come up with the child. We know what the child functioning, how the child functioning at home, how the child functioning in the classroom across different routines, and also identify what are the parent concerns, what are the parent preference. Then we set in the functional goal based on the parent concern, parent preference. EPIC team, we set a functional goal for the child for the next 6 months, what we call it IEP, Individualized Educational Plan for next 6 months for the child. Then we do the functional intervention. So before implement intervention, the EPIC team, we like to have a lesson plan meeting with the whole team member. During the lesson plan meeting, we discuss about the child goal, how we're going to implement treatment. So for example, at the PT, so my next 2 weeks, I'll be going during my arrival time. Then following 2 weeks, I'll be going during music time. So this is the way we plan the lesson plan. Then we try to do our intervention during child routine in the classroom. Then finally, we do the functional outcome. After 6 month duration, we review the case and we measure the outcome. As a clinician, when planning my intervention in EPIC setting, I'm always thinking about this triangle here. This triangle is about individual, environment, and task. What individual? Individual is about child. What the child diagnosis? Does the child have any associated medical condition? What the child age of the child? So based on all the information, we consider the functional aspect of environment and task to support for more holistic outcome for the individual. Environment is not only about physical environment, it's also about people who are involved in the child intervention. For example, parents, other caregiver, professional, doctors, specialists, those people involved in child intervention. We talked about what the child doing, what the child doing, how the child engaged during the task, how the child, whether in order to complete the task, the child able to complete the task independently or someone to help to complete the task. When people talking to the child, how the child responding to people. So all those information very important. This holistic approach will help me to plan my intervention well, embed the treatment strategy during the routine, and engage child meaningfully to achieve your functional outcome. So how the functional intervention happened at SPD EPIC Center? As mentioned earlier, we try to do our intervention during child routine in classroom. For example, at the physiotherapy, I support the child during arrival time. So when the child arrives at the EPIC Center, I helping the child to transit from the main entrance to the classroom by asking the child to walk with a walker or walk with any other walking aids. Then after 2 weeks, maybe I will go into another routine called music movement. During music movement, as a therapist, I will try to facilitate the movement of the child and actually position the child in a way to lengthen or to stretching for a particular muscle. Here, over here, I would like to share one video of functional intervention that happened at SPD EPIC Center. So here the child is standing in the wagon. This is a second time child standing in the wagon. The person who is standing in front of the child is a speech therapist. The other person is the teacher. EPICs are really focusing on transdisciplinary approach. So this is a function. See how the child communicate when she wants more. So this is called really a functional intervention. In SPD, we are actively and meaningfully engaging child in the community where they live and participate in the community activity. For example, physiotherapists are conducting aquatherapy program in a community pool and bringing children to the inclusive playground. The idea of doing this activity to giving opportunity for the child to play with a sibling and a friend. So during the session, we are always encouraging parents to bring the sibling and the friend during the session so the child will be more motivated and feel more functional and natural. Or things what they seem. Child may have ended EIPIC with a diagnosis of cerebral palsy. However, for case of CP mimic, when the disease of progression is not in line with the natural history of diagnosis, so in the case, we may have to revert back to the hospital. Then we always encouraging parents to continue follow-up care with the hospital. Now coming to my summary here, it's important to integrate both the diagnosis and functional thinking to optimize the functional ability of child, to enable families to integrate and be part of an inclusive society, to be wary that the initial diagnosis may need to be reviewed. Thank you for listening so far.
A very good day to everyone. My name is CK. I'm the father of Ryan, a very special boy who has been our pride and joy for the past 13 years. Today, I'm honored and privileged to be able to share our journey with you. This sharing will be divided into two parts, from birth to diagnosis, and then the different facets of life with Ryan. Ryan is our only child. He was born on 20th August 2008. The original plan was to induce labor in hospital, followed by natural childbirth. But the plan changed on the day of delivery due to fetal distress. Ryan couldn't wait to come out, so they had to take him out by C-section. The birth itself was uneventful, with a pink, screaming, and kicking little fella weighing 6.5 pounds at birth. However, things took an unexpected turn on day 3, when Ryan became extremely lethargic and difficult to rouse. He also refused to feed and developed seizures later in the evening. A CT scan showed that there was some minor bleeding in the brain, and he spent the next 8 days in neonatal intensive care before being discharged home on day 11. Over the next few months, we noticed that Ryan would startle easily and was sometimes fretful and impossible to pacify. He also often threw his head back in a rather unnatural position and arched his back. The doctors diagnosed it as colic and reflux and prescribed medicines. However, things did not improve. One day, an experienced pediatrician noticed Ryan's strange posture. He called it the fencing posture. We also began to notice how Ryan had occasional stiffening episodes. We were referred to a neuro colleague who ordered an MRI, EEG, and further investigations. The MRI showed significant anomalies in Ryan's brain, and the video EEG revealed abnormal brain activity. I recall the first family conference with the medical team. They informed us that there was some damage to Ryan's brain, as well as the preliminary diagnosis of cerebral palsy. Nonetheless, they were upbeat about the prognosis, assuring us that with early intervention, Ryan would probably lead a normal life. Unbeknownst to us, the team were also investigating rather worrying biochemical anomalies that popped up in the blood work. They even sent a sample of Ryan's urine to an Australian lab for further tests. I received a call from the neuro team on Christmas Eve 2008, requesting for an urgent meeting. When I queried about the results of the urine test, she was tight-lipped, suggesting that we discuss this in person. I suddenly had this knot in my stomach, this sinking feeling. The results of these investigations would forever change our lives. 26 December was D-Day, Diagnosis Day. Just like how the Normandy landing changed the course of history, the diagnosis changed our lives forever. The condition had a name: isolated sulfite oxidase deficiency. Not much was known about the condition, and there were approximately 50 cases in medical literature at that time. All we knew that it was a rare inborn error of metabolism, which caused developmental delay and regression, dystonia, ataxia, and dislocated lenses. Most alarmingly, the disorder was supposed to be fatal in infancy or early childhood. Later on, genetic testing confirmed the presence of known disease-causing mutations in Ryan's DNA. We were stunned. The journey to parenthood was tough, and we were elated when my wife got pregnant. We had chosen to name our son Ryan, which means Little King. As both my wife and I served in the armed forces, we gave Ryan a Chinese name, Rui Jin, which translates into a heaven-sent soldier. All our hopes were now dashed with the bleak prognosis. Ryan would never become a pilot, a general, or scholar, and will need constant medical care for the rest of his life. The shock, sadness, and despair that we felt made it the darkest and most miserable Christmas ever. But instead of moping and pining over something we could not change, we accepted the reality that Ryan would be someone very special. We resolved to look to the future with hope and promised to give Ryan the best life that we can, to shower him with love and care as we journey this windy road together. Living the life. Ryan's medical condition was quite a roller coaster. After the first 5 months chasing the diagnosis, we spent the next 3.5 to 4 years treating various conditions associated with the disorder, like epilepsy, reflux, aspiration, recurrent chest infections. Things actually reached a head when he was about 3.5, when he had bronchitis for 3 consecutive months, repeated episodes that resulted in drastic fall in his oxygen saturations. That's when we decided that we had to stop feeding orally, do a gastrostomy and fundoplication, and start feeding through a G tube. The next 2 years were blissful, renaissance, the golden age. We no longer had issues with feeding, and Ryan had no longer had issues with aspiration and bronchitis, and the number of hospital visits fell. However, it didn't last very long. When he was about 7 or 8, the reflux continued to worsen. He started to aspirate again, and we wound up in hospital very, very often. Finally, we had no choice but to stop G feeding and proceed to J feeding with a pump. In spite of that, Ryan continued to get repeated chest infections. He also developed a liver dysfunction. As you can see from the image, he became jaundiced. His skin became extremely sensitive, where a mere scratch would result in a yellow line. And he also developed bruises. But those are just all but life's nasty surprises. Living with Ryan's condition meant that we had to make continuous changes to our lifestyle. First, there were the medical visits, the hospital visits. They were fairly frequent at first, and then we had the golden age where they tapered off, and then they resumed with a frenzy after that. You know that you've been to hospital too many times when the car barely recognizes your car. At times, my wife and I would be living out of Ryan's hospital room we were both on the armed forces then, and we would have our uniforms in his room and take turns going to work. Things were really crazy then. In addition, Ryan has very special medical and dietary requirements. His diet comprises of low protein, methionine, cysteine-free formula that's made up of powders that need to be imported. They are made in small quantities and some have a 5-month lead time. So we have to measure these powders every day to make his 5 feeds. And then we have to ensure that we continue to be able to replenish this supply. Likewise, his medications have to be weighed, they have to be mixed, and they have to be administered. But that's just part of living with Ryan. Moving on to J feeding, we had to make provision. We had to modify his chair and to make provisions to ensure that he could continue to attend school in spite of having to use a pump. And as Ryan grew, transport became a problem. It became more difficult to put him in a car seat, so we switched to a harness. And finally, we purchased a vehicle with a wheelchair ramp. In spite of the challenges, we do not keep Ryan cooped up at home in a bubble. Family outings are great moments to bond and create memories. Ryan also enjoys taking in the sights and sounds of his surroundings. So we make it a point to bring him to the malls, parks, and other venues regularly. We are also constantly looking out for suitable outdoor activities that we can do together. For example, this was Singapore Air Show 2018, which is held once every 2 years. In addition, we also bring Ryan to various parades like the National Day Parade. And we often get the best seats in the house, being in the wheelchair box right in front of all the action. And finally, we celebrate every birthday. We celebrate life, especially at the major milestones. Ryan also attends a special school 5 days a week. We drop him and his nanny off in school in the mornings and pick them up when school ends past noon. The transdisciplinary program is specially tailored for children and teens with multiple disabilities and is run by a dedicated team of specially trained staff and healthcare professionals. It includes class time, sensory stimulation, and an integrated physio, speech, and occupational therapy program. Ryan enjoys going to school and being in the company of friends and teachers. The school is also well equipped with an extensive array of assistive devices which can be tailored to meet the needs of individual students. In this photo, a speech therapist is using the Tobii eye tracker with Ryan. Ryan tracks fairly well, and it is hoped that he would be able to use a device like this to communicate with others. We are currently also working with push buttons and switches to determine what the best options are for Ryan. In addition, the school organizes outings. Here you can see our champion scoring a strike during a class visit to the bowling alley. We acknowledge play as a crucial element in family bonding and child development. Specifically, we want to condition Ryan to recognize cause and effect, and also to encourage exploration. Here, we entertain Ryan with a simple card point. He's also thrilled to activate the tap by moving his hands for his 8th birthday and had a great time on the slide. We also try an increasing number of inclusive playgrounds that are springing up. In this clip, Ryan is clearly enjoying the experience as much as we are enjoying our time with him. Since young, a dip in the pool has always been one of Ryan's favorite activities. Regular swimming rings and flotation vests don't work for Ryan due to his dystonia. a dual chamber neck float seems to work best as it keeps Ryan's head clear of the water at all times. You can see the joy and glee as he discovers the freedom of being able to kick his legs and turn around in the pool. Physiotherapy has been a mixed bag for Ryan. We did do intensive physio in his early years with the aim of eventually getting him to be mobile. We were super excited when we could get Ryan into a crawling position. We also purchased a used walker in the hope that Ryan would be able to translate some of the kicking in the pool to propelling himself around the house. But his regular hospitalizations were disruptive to his progress. It was always one step forward and 2 steps back. Eventually, we focused remaining efforts on stretches and preserving the range of motion. Given the poor prognosis and neuromuscular nature of this process, we have decided against the physio intervention and instead work with the neuro and physio team from National University Hospital to manage his condition through more conservative approaches such as medication, postural support, and neuromuscular stimulation. I will take a short break and let you view a clip of Ryan and
my son, try to walk.
你要相信，相信我们。
My wife and I enjoy traveling, and we spare no effort in enabling traveling for Ryan. This slide shows the places that Ryan had been by the time he turned 8. Probably more places than most folks do in a lifetime, but that is precisely the point. To squeeze a lifetime's worth of travel into Ryan. It includes a trip to Disneyland Orlando just past his first birthday. I joked with my wife that every kid has to do the Disney pilgrimage at least once in his or her life. With Ryan's prognosis then, we shouldn't waste any time. So we went to Disney. But joining a conducted tour is close to impossible with Ryan's care requirements. So the trips have to be either customized tours or self-drive. A lot of preparation and planning are well worth the effort. The previous clip of Ryan's travels ended abruptly during our March 21-8 excursion. That was exactly how that trip ended, abruptly. Ryan's liver function had been in steady decline since July 21-7. By March 21-8, he was jaundiced and swollen, and his skin was becoming extremely sensitive. He was also beginning to bruise easily. One of Ryan's principal doctors privately assessed that Ryan probably had months left. So at our request, the medical team optimized his medications and permitted one more short overseas vacation to Tokyo Disneyland. Again, we wanted to bring our little boy to the happiest place in the world. and make one more happy memory for the road. Unfortunately, his condition deteriorated rapidly while in Japan. We cut short the trip and rushed home. An unresponsive Ryan was rushed directly from the aircraft to the intensive care unit on arrival in Singapore, and then discharged into palliative care at home the following day. This clip chronicles how bleak the situation appeared on 31st March and 1st April, and the miraculous recovery that Ryan made, which stumped all of us, including his doctors. Ryan eventually made a full recovery following introduction of additional drugs and a change in his feeding pattern. We celebrated his 10th birthday on 19th August 2018 with a Superboy themed bash for friends and family who had followed Ryan's story and been our pillars of strength and encouragement throughout the dark days. We also took Ryan back to Tokyo the following April to finish some unfinished business, to complete that aborted trip to Tokyo Disneyland. We stayed at the same hotel, and the hotel staff treated Ryan and the family like VIPs during the entire stay. Everyone was very happy that Ryan had come back. Ryan officially became a teenager 6 weeks ago and remains the cheeky boy that he has always been. He still attends class 5 days a week, and his warm smile continues to spread cheer to all those around him. This brings me to the end of my sharing. I hope that it has been useful. My key message is that miracles happen, but don't live life waiting for one. We strongly believe that life is about quality and not quantity. So please enjoy the journey, and whatever will be, will be. Once again, thank you for giving us this opportunity.
Thank you, CK, and all the speakers, and Chandra and Prof. Stacey for all your input and stories. I now open the floor to any questions and answers.
Okay, this Prof. Kwa here. This is for Stacey. I know somebody who works for Secret Lab. Those the youngsters would know. Secret Lab is a very flourishing Singapore startup that makes computer chairs. Yeah, and they have sold, I think, many of them. So they are one of the richest startup. So I just wonder whether we can appeal to Secret Chair to the work on special chairs for these kids too. Stacey?
Actually, the best person to answer would be Laura, because she does a lot of fitting for our patients. I think the challenge about the special needs chairs is that it really has to be customized to the child exactly, and that it's not just a commercial product that we can throw out. But while there are many tools, many options out there, and truly the chairs are very different from, I don't know, Prof. Kwa, if you remember, long ago we had something called the Grow Workshop. So you remember those chairs had the blue cushion, and they were all kind of rigid and hard. So the technology has changed a lot. But I think one of the things that we recognize is that for a commercial entity to to come up from a computer gaming perspective
Yes.
to go into some of these specialized supports may be quite challenging, because it's really an expensive as well as you know, it needs a lot of expertise and coordination to create something like that. But one day, if you are free, come down and have a look at what Laura, Melody, and Rachel do, because it's really amazing to see the new chair bags, the new seating systems. I think they have much more comfortable seating than I do in clinic. But I think it's necessary because, you know, things like feeding and you know, making sure you don't get pressure sores, all this is actually within that system. Laura, do you want to share anything about what you about the current state of affairs?
Yeah, before Laura, just to say that we always have the ideas that is the rich people and the CEO and his team are so young. Okay, so so they earn tons of money. So it's time for them to show show some kindness. Yeah, and actually, if they succeed, you know, they may have another line. They can earn even more.
Prof, I am more than happy to meet with these people to see what we can do for these kids that fall in the gap where nothing is available commercially. Usually also we have to consider a lot of other issues like logistics of how to get the chairs into the house, into the car, into the school.
Yes.
And access issues. But certainly I am more than happy to talk to anybody that you can link me up with.
Yeah, okay, yeah. Okay, thanks. Yeah.
Thanks, Prof.
Wei Xiong asked a question, what are the support measures available for patients and their families when these individuals become adults? This is an international problem. Most countries after the age of 18, their children are actually pushed out of the pediatric care. But thankfully in NUH, we continue to look after our patients who have child onset disability till well into adulthood. And I'm very sure Prof. Lau can attest to that she has patients that are older than I am, which is past the half decade. I think the new thing now is to actually manage parents' expectations of where to optimize the child's function and not to try to fix the disability so that they become normal, because that clearly is not possible. But it doesn't mean that the family can't have a good life. And you can see from the Song family that they make the most of what they have and what they can do. CK, do you have any comments?
Yeah, actually, I think there's also the Special Needs Trust Company, and then which conducts talks on planning and for the future of such kids, setting up a trust for them in the event that parents are no longer around. I've attended some of those talks, although I haven't quite followed up, but I think that could be another useful avenue. There was also a question that just popped up about whether I think the government has been doing enough for me and Ryan. I think so far the school has been awesome. The special needs schools are heavily subsidized, and Ryan attends a school like a normal kid. And as I had mentioned, there's an integrated program of all the various therapies, which I find has been quite useful, and all for a very affordable fee. So I think for Singapore citizens, we're quite happy, we're quite privileged to have this kind of support from the government. And then of course, medical care wise, we've got the team at Khoo Teck Puat to take care of us. And I think Laura has, Laura sees all kinds of patients as well. So I think from that perspective, no complaints there. I think everything's good. But again, I think we also have to temper expectations of what we want. I mean, it's a question of resource as well. And again, expectations are, I think I'll leave it at that.
Thank you very much. With that, I would like to thank all the speakers once again, and we will call this session to an end. Thank you very much, everybody.